Greetings from Galaxy Care, Pune, India. This is a Gravida 3 Para 2, previous 2 cesarean section, presenting with PV spotting for 8 to 10 days, having taken MTP pills 3 weeks back. On transvaginal sonography, we are seeing a hypoechoic avascular mass in the upper part of the fundus, representing retained products of conception. The plan is to remove the retained products by using the tissue retrieval system. You can see the vaginoscopic technique. We are removing the blood-stained mucus and now entering the cervical canal, which is identified by the arborvitae. But as we move ahead, we encounter stenosis in the upper one-third of the cervical canal in the form of fibrosis, which is clearly demonstrated in the video. We introduce the incisor blade into the stenotic part, and with judicious use of the suction which is on the handpiece and circumferential cutting, we open up the stenosis gradually and steadily. We also use a combination of the bevel of the scope to move ahead. But as we go ahead, we enter further stenosis just below the internal os, and here we use the circumferential cutting and judicious use of the suction. Not too much suction is applied to prevent pain. And now, as we see, we are approaching the internal os, which is seen as a crescent, and this is approached with the bevel of the scope. The continuous flow irrigation helps us in distending the cervical canal and opening up the cervical canal and the internal os. But at the level of the internal os, you can clearly see there is stenosis. These fibers are white. These are do not have any innervation and no vascular supply. Again, using the same technique of circumferential cutting, judiciously using the suction on the handpiece, we cannot use too much of suction, cannot pull too much on the cervical canal, otherwise the patient will complain of pain. As patient is without any pre-medication, no form of anesthesia is given to this patient. It's an in-office procedure. You can very well appreciate the fibrotic white fibers, and you can see the position of the internal os, the incisor blade and the fibers, and this is what we say as circumferential cutting, which helps us to move ahead and deal with the stenosis. Now we move with the bevel of the scope towards the internal os, and you will now appreciate that the uterus is retroverted. So what we are seeing is a retroverted uterus. Here we have to lift our external hand of the scope so as to enter the cavity. Gradually and steadily, without any pain to the patient, we enter the cavity. We suck out all the collected blood and inside the cavity. And now we place the window of the incisor blade onto the apex of the RPOC and apply suction on the handpiece and cut with the pedal being pushed on the foot pedal. Gradually, all the RPOC is removed and all the tissue is collected in the canister. Now, we are supposed to approach the base of the RPOC to remove whatever is remaining from the base. In a single insertion, we have been able to remove the RPOC. Now we approach the base of the RPOC, remove whatever is remaining of the retained products. Here there is no bleeding as it is a type 0 to 1 RPOC on sonography, that is the Gutenberg classification. You can now clearly see the right ostia. So under vision, in single insertion, we empty the cavity, and as we withdraw outside, you can see the amount of fibrosis in the upper one-third of the cervical canal and at the level of the internal os. And this is another technique to deal with the stenosis by using the tissue retrieval system in office with a visual analog score of 4. Thank you so much.